So we're going to break this up and do it as a team. And a couple concepts we're going to bring across to you all is listen to what's the key themes to all of us who are coming up here and discussing this with you all. As Dr. Hovind said, there's not one model that's going to fit everybody. You're going to have to adjust it. So I want to challenge you all to listen to certain key themes that Grace has spoken of. You're going to hear from us and figure out how they apply to you. In the interest of not trying to be too repetitive, just a couple of things, what key is and what we're going to try to cover today. Key is primary care based. The data clearly shows if a patient has a primary care physician and they see that primary care physician on a regular basis, they have better health outcomes and lower cost. From a quality perspective, we see the trend being basically the HEDIS data and how that's going to be pushed through and how we should be leveraging our practices to follow that. Shared cost savings contracting is the theme of how we're approaching the ACO concept at this time. We are independent practices. We want to stay independent. But to stay independent is going to require a lot of interdependence of the primary care physicians and the specialists, which creates some unique cultural pieces, but ties in also in what Grace has said is data. And you've already heard tracking your data. How are you going to track and see the improvements? So from all of you have different EMRs. One of the questions is going to be, as we face in Key, is how do we integrate all that data across different EMRs to get the data that we can show what we're doing? Because we want to use our data, not the health insurance company data saying, oh, here's how you're doing. We want to be able to go to them and show, here's our data, here's how we're doing it. You know, who do you want the fox and chicken coop here? If you want them running the data and just cleaning it, or do you want to be able to present the data yourself? Another key thing is population management and how you're going to do it. Value-driven healthcare, not to beat a dead horse, but definitions, basically health outcomes per dollar spent. Outcomes, again, HEDIS, patient metrics, and then cost is how, what is being spent and how is it being covered. Most likely, we're moving towards some type of universal coverage. Delivery systems are going to be full cycle of care, medical condition based, i.e. diabetes, COPD, heart failure. Reimbursements, moving towards bundle. But what does that mean, bundle? Bundling, again, is going to be how it's going to apply to your specific situation. It can be the activities that you're doing, getting compensated for being a population manager. It also can include fee-for-service, procedures. It's going to be a compilation of all this. This is a busy slide, but hopefully it gets across that concept of figuring out where you are on the continuum. Across the bottom axis is you have practice size, everything from small practices to fully integrated systems. That size is going to determine how you can play in this game. On the axis on the left is how you're going to get compensated on a basic perspective. Is it going to be fee for service? Are you going to get global fees? Are it going to be DRGs? Is it going to be more of an integrated capitation? Figuring out what size your organization can be to actually handle how it's going to get paid. Don't try to go and be something that you're not, or try to bite off something in a reimbursement model that's just not going to fit your size and how you work. Which also then gets to how you can be, the incentives that could be applied to you all. Again, simple process stuff. If you're small, keep it simple, keep it practical. The larger you get, the more integrated you become, the more leverage you have to use the data to show quality improvements, process improvements. So again, this is a framework for how we see ourselves and where we fit. Conrad's going to talk to us a little bit about where we come from, and then we'll build on where we're going.
Yeah, so we're in a unique market in Wake County for the most part, and when we looked at how we got ourselves put together, and I'm going to go forward and then come backwards just for historical purpose. The IPA started in 1994 as a way of getting people together when small practices and with insurers were having more trouble getting contracts. So we were a messenger model. A group of people got together, decided it's easier for one person to go out, it's easier for the insurance company, it's easier for the practices. We may get a little better reimbursement. It worked out for a number of years and did pretty well. In 1995-96, when HealthSource was big in our area, we entered into the contract like many other people of taking some capitation, and like some other people, it ended up not working very well for us. They had the data, we didn't have the data, and that made it very difficult. You didn't know what you needed to take care of that population because that was not what you did for a living. You took care of patients. They took care of data, and that made it difficult for us. Through the 2000s, early 2000, it was really doing some of the same fee-for-service, but we did some things with Blue Cross Blue Shield and some pilots looking at specific programs where we're getting paid for performance. Could we keep the asthma costs down? Could we keep ER utilization down? Some other things where there was shared money that actually helped us keep our IPA running at that point in time. It was about in 2009 late that we figured out as many practices were in our area were getting bought out by larger organizations and that the small independents no longer had any clout of getting any kind of good contracts, that we need to do more. What could we do? There was a large push by a large number of our membership to become a single tax ID. And there were a lot of problems associated with that, the least of which we were about 45 practices at the time. Most of us at that point weren't on health EHRs at all. We were using multiple EHRs. We were practicing different styles. So we sat down and for about a year we talked about doing this. The board itself at that point in time knew where things were going when we were looking at quality. So as we started doing this, one of the things that came out was we need to be a quality healthcare organization. And so we said, we'll put this together, but it has to be a quality organization first, and you have to meet certain things, and then we'll look at becoming a single tax ID. So we dropped the whole single tax ID thing beginning in 2010, and what we then said is, we want everybody to meet certain standards. And the standard that was the easiest one to pick was to say every member in our organization has to be a patient-centered medical home, level 2 or level 3 by the end of 2011, or you're no longer in our IPA. It was a big step. Most everybody stepped up to the plate. We ended up losing 5 practices along the way, which we have since replaced, and we now have a number of others behind us. But what that did is it created an environment for us that we now were taking this seriously. We knew where we were going. We knew we wanted to provide high-quality care as an organization. We wanted to keep costs down. Then we would look at how we could integrate, become more interdependent as we move forward. Well, that got the attention of some people. So that's what set us apart. So this is what the environment is in Wake County. We had key IPA, now about 220 providers. Primary care, we have a couple of GI and a couple of pulmonologists, a very small percentage. In a county that dominated by large groups. UNC, Wake Med, Duke, as well as Novant has a smaller but still a significant presence. Even though they're small, they're still, because of their size, able to get much better contracts. So as we move forward, one of the organizations then, a national insurer with local presence, came to us, knew what we were doing, and said, we're looking at expanding. We'd like to use your organization as a way to keep costs down. We then realized we're heading in the right direction and we need to pursue this. That contract we didn't take because there were way too many downsides for us and really no upside except for the insurance company that could expand their market and pay us the same not so good rates they'd been paying us forever. So that allowed in, and then we had another national insurer with a local presence who came to us, as well as a local employer that was announced, First in Health through Glaxo, that used our IPA to run their 11,000 local employees through the CCNC network, Medicaid in North Carolina, to use our providers in order to keep the cost down for their things. They would then pay for the care coordinators through CCNC as well as some other things. So that's where we started. It has led to us now being, as I said, with this slide, we now have 11 practices joining, another 35 in plane to get their PCMH and come on board. We're looking at more than just, our goal is to be not necessarily an IPA, but to just branch our network out to anybody who wants to be independent and share this common goal with us, and then figure out how we then progress to get the data in, move forward, how to evaluate that. We have a quality care committee that is using HEDIS standards and doing those things that go with us as well. So currently what we've done in this last year, starting in 2012, we have through Blue Cross Blue Shield signed a contract that will give us 30,000 covered lives, and with Cigna that will give us 14,000 covered lives. So that's where we're starting. We're kind of on the backside from everybody else and trying to move forward and learn, knowing that we need to be quality.
So next question is, how are we doing this? Our models of care, patient, as Conrad stated, the patient-centered medical home, focus on the patient, focus on the patient, focus on the patient. How do you get the health and safety of the population and that patient you're looking at, and how do you improve affordability? Patient-centered medical homes, BQPP. Next level up, sort of the way we see ACOs on that continuum is this patient's medical home on steroids, really taking it to the next level with respect to coordinating care and integrating the practices across from a primary care perspective. That leads us to the next phase, which we're planning in now, is how do you clinically integrate? How do you take all these primary care practices, these different EMRs, the subspecialists, how do you create a communication system? How do you track all this data? And oh, by the way, how do you how do you do population management at the same time?
So if we look at what happened when we signed those two contracts, the insurer told us which hospitals we could utilize in the county, which hospitals were the high-quality, low-cost hospitals for them, sharing then data with us to help us figure out how to pick the specialist, who cost the most, what the quality measures they had on those people. So once we enter into this relationship, there's a lot more transparency. As we said, how do you control costs in the health care? Patient needs primary care as their usual source of care to help direct the right kind of care using the right kind of people at the right time. And that's what, by opening that box with the insurers, that we now have access to that data and can look at that and evaluate it, can help us build the kind of model that we need from the ground up as opposed to the hospital down.
Next slide is more just a summary again of key themes that I mentioned earlier, IT, quality, and our evolution on that continuum towards clinical integration. I put up the next slide in direct violation of what I was taught in business school, which is keep your slides simple. But I wanted to throw this up here as definitions of ACO. I threw it up here for a couple reasons. One, if it takes this much language to explain a concept, it was probably written by a lawyer, and does it pass the smell test? So what we try to do is try to gel it down to what we think is important. So for key, our ACO is a provider-led organization. We're looking at the full continuum of care, lowering overall costs and the quality from a shared savings perspective. We are not taking it on risk at this time in managing the population. How do we do it? In our network, we see it as the medical home, evolving in a data perspective, the subspecialists, and then evolving into that, the ancillary services. Again, built on primary care. The contracting, basically looking at the medical home, we have what we call co-management agreements. We reached out to the specialists, we reached out to urgent cares, and are forming this network of agreements about how we want to communicate together and how we want to share the information. We're using an electronic tracking system and a referral system to try to bring everybody together that's being provided by a third-party provider. Population management, care coordinators. We have our first care coordinator in place, working on a defined population for a specific insured group. Using that, starting small, figuring out where the bang for the buck is, and then building from there. Identifying gaps in care and trying to manage the high-risk patients. Using evidence-based management. Our current tactical focus is, as I mentioned, urgent cares, the Cigna designation, the Blue Cross Blue Shield, and the co-management agreements. We're trying to push through the philosophy is broken out or elaborated in these chosen wisely system of each subspecialty saying, hey, look, here's what's practical, here's what works. We really should be doing some of this stuff and creating common education across all these independent entities. Preventable events. So where are the costs saved? Basically avoiding ER visits, minimizing hospitalizations, reducing the bounce backs, and then working with your focused subspecialty networks. Delivering the population management piece is what we're starting to grow into. It's going to be one of the biggest challenges I think we have and ACOs will have in how to manage that. Our medium-term priorities are looking at how do we bring HEDIS into our systems and how do we start adjusting for costs and the cost variances. Cost variances, again, predominantly are the specialists and how we're going to work with the specialists. Way we're approaching the specialists is that at the present time we are looking to our insurance providers to provide us that list. We're not sitting here saying you're in, you're out. We're using the insurance companies to come to us and say, here's who are part of our quality networks, and working with them first and expanding from there outwards. The next piece of it is information technology, and you hear that as a consistent theme through here, and how to engage the patient. The last piece of it is, where is the market going? We see the market going in a tiered perspective. There's going to be very focused, basically, patients who are going to be high price sensitivity, probably high deductible plans, and they're going to be very narrow networks, both at the CMS level and the third-party providers and the insurance companies saying, here's how we're going to manage costs. It's going to be a very defined entity, very case-specific. Probably as the patient becomes, or the groups become less price sensitive or more broad, the population management complexity will increase. And that'll be probably one of the key drivers for all this. At the end of the day, for Key, we're primary care based. One of the key things for us is quality. It's going to be HEDIS based. We are doing shared cost savings at this stage of our evolution. We're not doing any type of risk assessment. We are independent. We want to stay independent, but we also see that it's going to be an interesting challenge, because how do you remain independent by becoming more interdependent? The last piece of it is data systems, which is a consistent theme, and population management.
Yeah, so what we know is that, 70% of the healthcare dollar comes from chronic care. We know that. We also know that the easy parts about saving money in the system are cutting down on the hospital admissions, readmissions, and cutting out ER visits that are unnecessary. That's pretty easy. And we may get a hold on that pretty good in the first couple of years. But where do you go from there as far as disease state management? And one of the things that's critical from a primary care standpoint when we pick our strategic partners, be in our specialties and urgent cares and hospital, is looking at the data and making sure that we're getting good data from that. We've already done some of this. There are groups that may look per patient, per visit that patient goes to their office is cheaper, but they may not be doing the difficult thing. They may be not managing the whole patient and sending the more difficult patients on to a tertiary care facility, which then are costing us more money. So you have to be real careful if somebody shows you data as a primary care. I'll just pick GI as a nature, that their cost per endoscope may be cheaper. But if you look and drill it down, every fifth, sixth patient they're not seeing, they're sending on to Chapel Hill or Duke and costing the increase because they see those patients as more high risk. The second group may look a little more up front, but when you look at the overall global cost, are cheaper because they're keeping the people in the community. So you have to be real careful as you move forward about who you pick your strategic partners and move beyond that first level in evaluating.